Labrīt. Mani sauc Līga Frīdenberga, es esmu bērnu slimnīcas aprūpes vadītāja, bet šobrīd šeit es esmu kā asinsvadu projekta viens no realizētājiem. Un pavisam īsi, tātad pagājušajā gadā organizējot vienu pasākumu uz es jums to stāstu, tāpēc, lai jūs ticētu, ka lietas var notikt, ja tad jūs tātad brīvības pasākums anestēzijas un intensīvās terapijas kongresā norganizējāmies ar Ultrasound and IV, kuru jūs arī varēsiet uz Ultrasound and IV postu, man atbildēja Denis, vai forši, mēs to darām ar māsām. Viņš var mums kaut kā palīdzēt, ja mēs to gribam. Protams, es kā normāls latvietis nedēļu vai divas staigāju apkārt un domāju, kā man kaut kāds amerikānis uzrakstīja, ka viņš var mums palīdzēt. Ja kas, tas ir tieši tas pats amerikānis, kas stāv jūs priekšā, kas ir māsa Denis Lu no Amerikas. Viņš ir arī asinsvadu eksperts, un viņam varbūt nav tik daudz zinātnisko grādu kā citiem, bet viņam ir ļoti liela iedvesma un vēla dalīties. Un tad, kad Denis atrakstīja, ka viņš pie manis var atbraukt, pie mums var atbraukt uz 2 nedēļām, tad man palika žēl, ka mēs viņu paturēsim tikai bērnu slimnīcā. Ok, jūs taču visu runājat angliski, vai ne? So I was telling you a story about last year.
Yes.
Me not believing that you can come, and then finally when you said that you will come, and you will come for 2 weeks. And then we decided that it's not fair to keep you just in Children's Hospital. It's not fair to give this opportunity just for nurses, because we know that it's always difficult to correct something. Sometimes it's much more easier to do things right from the beginning. So this is why we were in Latvia University, and as we know in Latvia you had 2 universities, and I'm quite close to both of them, so this is our last day. So we have worked like 12 days in a row. This is group number 14, in the afternoon will be group number 15, and we had 1 student's day in the university. They had 1 group, so you have 2 groups. I hope you will enjoy. There will be a lecture, and after we will divide you in 5 groups, and we will go 5 workstations. So probably those who are far away, they can come closer. You will see, you will feel the energy. You will see everything the same, but you will feel the energy. And then after, we have debrief with some questions and an opportunity to make pictures for social media. So, Dennis?
Thank you. Can I get could you bring me a large and a small syringe from the other station? That'd be great. Okay, so we're going to talk about flushing. How many of you have flushed with a syringe before? Good. Okay, now, how many years with your fingers have you been flushing with the syringe? Give me 2 years, 1 year, 3 years, 10 years, 20 years, 30 years? Don't answer that one. Okay, so you've been doing it for a little bit. We've been doing this for a long time, and through new research, we're finding out that there's different ways to do things. How many years have you been walking? Don't answer that one. We've been walking for a long time. But how many classes have you taken on walking better? That sounds crazy. But we're finding out that there are new things to discover. How many of you heard, why fix something that's not broken? Why fix it? No. Why fix it? It's not broken. Leave it alone. Because we intuitively know that it is broken. There's something wrong. There's something there we can do better. And that's why we look for changing things up. So we're going to go over something as simple as flushing, as simple as dressing changes, as simple as aseptic technique, and go over why it's so important. So we have high pressure. When you flush, do you know how hard you're flushing? Yes. What's the number? How many millimeters of mercury? How much pressures per square inch? You don't know. Don't worry. We'll find out today. Pulsatile versus laminar. Do you do one small push or one big push, or you do push, pause, push, pause, push, pause? Number 1 or number 2? Number 2. Okay, good. Why? What's the difference? Who cares? We're going to find out. And then catheter extravasation. When the catheter comes out of the vein, that's the problem. That's when medication leaks into the subcutaneous tissue and it doesn't work. And then of course, blood refluxing into the catheter. You don't know this. You will not know that blood is going into the catheter because of one little thing. And I'll show you what that is. All right. So the answer, low pressure laminar, low pressure, very one, not push pause, but one slow push for peripheral IV. And then for central catheters, it's push pause, push pause, push pause, with a little bit more pressure, okay? And then adequate vein purchase. You need enough catheter in the vein. If you don't have enough catheter in the vein, it's gonna come right out. And then of course, correct clamping sequence, we'll talk about that. Okay, high pressure. Anybody, did they teach you this in school? What is it? Gotcha. What is varicose triad? Don't worry, someone said we learned it in nursing school. I don't remember. Okay, varicose triad are the three main reasons why we create thrombosis, why we have clots. So, endothelial injury is damage to the vein. Stasis of blood. Blood's supposed to move fast, but if it moves too slow, we start to develop clots. And if it stops, we develop clots. And of course, the patient disease. We're going to talk about endothelial injury right now. Please say yes. Did you know that there was blood in the vein? Yes. Okay, okay. Did you know that there's a cell called endothelium on the inside of the vein? Okay. Did you know there's something in between? It's called glycocalyx protein. Don't feel bad. I didn't know about this either until 2 years ago. Okay. This is new research. It's fascinating. The glycocalyx protein is like a gel layer. It's like a force field. It's protecting the veins from the blood. It's protecting the veins from the blood, the cells from the blood. What does that mean? There are proteins in the blood. Have you learned, please tell me yes. Have you learned clotting factors? 1, 2, 3, 4, 5, right? Maybe not exact stages, but you know there's different clotting factors. Those are in the blood. When that touches the cell wall, it starts to clot. That's when the clotting develops. Have you heard, maybe for the nurses here, have you heard that diabetic patients have cardiovascular disease also together? What is glycocalyx made out of? Proteins and sugars. So with high insulin sensitivity, there's a lot of insulin all the time. So what's happening to our sugars? So that's a protective layer. When that's gone, that's when we start to clot. That's when we start to have thrombosis and inflammation. Don't worry, I'm not expecting you to read all this. This is for your teachers and educators to know that the definitions are here. And if the teachers are interested, you can have the PowerPoint. Linda will have the PowerPoint so you can change it, edit it, translate it, whatever you want. And you can keep all the videos as well. What is that? Is that a knife? Is that wood? Is it a dog? What is it? Anybody tell me? What was that? Uh-huh. Water. Yes. This is water. Ah, did it cut my mouth? No, but it cut his skin. What caused the water to cut the skin? Pressure. So question is, when you're flushing, how hard are you flushing that saline? Does saline cut our skin? No. We wash with saline sometimes. So if you flush too hard, what's happening to that endothelium? When you're flushing, has anybody flushed hard before? Don't answer that one. When you flush hard, what happens? Do the veins expand or do the veins collapse? Expands. That's why when we flush, sometimes when the IV is not good, it starts to bubble up, right? You're wrong. It doesn't expand. And I'll show you.
Your lines, your PIVs are clotting because the endothelium is being damaged by how hard you're flushing it.
And as you can see, there's a little bit of damage.
That cement gets degraded and damaged. Same thing is happening with the...
What's happening to the veins?
When you damage the endothelial lining of your vessels.
The veins are not expanding, they're closing, they're collapsing when we flush hard.
That area. So then what happens when you...
All right, so here's our base.
Here's another example of how the vein is reacting to high flushing.
Now we're gonna flush hard. We'll see what it looks like from here at baseline.
You see the veins collapse? They're not expanding.
Be slamming the flush. We're going to measure to see if there's any spasm in here. That's from slamming it like I used to in the ER. There we go. We'll compare this.
Look at what happened to the size of the vein.
To see if the vein shrunk
This is
at all.
immediate. This is not 3 minutes later. It's not 4 minutes later. It's not 30 minutes later. It's not 3 hours later. It's immediate. What is that called when the vein does this? Is there a word? Do you guys have a word for it? Venospasm. It's when the vein spasms. Why does the vein spasm? Because it's not happy. And so we have to be careful how we're flushing. We don't want the vein to stay angry, metaphorically speaking. Okay, shear force. It's that friction. The friction is what hurts and what makes the veins irritated. Do you know why we say the vein is blown and why we think it's a rupture or explosion? We've been making up this word for years, decades. Think about maybe 70 years when nurses were allowed to, 100 years when nurses were allowed to put in IVs. Why do we say it's blown? Take a guess. Be creative. Oh, okay, never mind. I'm going to move forward then. So in America, we say that, oh, the IV's blown. Because when we see the water, the saline swelling, we think it's an explosion, but it's not. It's not an explosion. If it exploded, it's a very big problem, okay? It's a very big bleeding problem. This is the study. This is the proof that showed that increasing in flow rate, increasing in pressure, essentially, the flow rate causes that shear force and friction, and so does the angle of insertion. I'm not going to go too deep into that. This is the math. I know it's too early for math, but I just wanted to show you that there's math, there's proof, there's data to show what I'm talking about. All right, catheter extravasation. What does this mean? Adequate vein purchase. When you don't have enough of the catheter in the vein and it pops out and we continue the medication, this is what happens sometimes. Not all the time, sometimes. I want you to take your arm and move your skin left and right. How many centimeters can you move it? Let me know. How many? About 1, 2, maybe 4. Okay, what about those who lost a lot of weight? Okay, elderly moves a lot. So if we put in this much, yes, it's good, it flushes, it draws blood, and then they move their skin, even though you taped it really good, you stapled it, you glued it, you melted it on the skin's gonna pull out the catheter from the vein. So keep in mind, this is an equipment issue. Your leadership does not know this is a problem because we don't know it's a problem. So now that we know, we have to raise the alarm and let the administration know. We need longer catheters. These short ones are failing and we're wasting a lot of money. Okay, so this is for you guys to know. What medication do you think happened here? It's an antibiotic. We give it all the time. Vancomycin. Vancomycin was continued. This is for the students. Don't let the ego nurses who think, I've been doing this for 30 years, you don't need to change anything. Don't let them influence you, okay? This is what happened this is what the 30-year experienced nurse did to this patient. The patient said, it's kind of burning a little bit. Well, If flush is fine, we're not going to take it out. We're going to keep going. Okay. Another day goes by. It really, really burns. And there's some red. It's like warm and it's a little red, little bit red. The nurse checked it. It was flushing well. Draw blood. Nah, we don't need to change it. We're going to keep going. Day 3, the patient said it's starting to swell. It burns and it hurts a little bit. Nurse flushed it. It went in without big swelling. She said, no, it's fine. It's normal for it to burn. It's vancomycin. Of course it's going to burn. And then she kept going and going. And after a week, the patient just ripped it out because it hurt so much. The nurses were telling the patient it's normal. Burning and pain in the vein is not normal. You're not going to know this, but I'm just going to say it for the cameras. I'm going to set aside propofol. Let's set that one aside. Let's set down the 0.0001% of medications. Every other medication, for the most part, if it burns, it's not normal. There are no nerve receptors inside of the vein. Outside of the vein, yes, but not inside of the vein. So when the patient says it burns, we have to do something. We don't have to stop the medication, but maybe we can dilute it, slow down the rate, something. This is soda, bicarb. This patient lost his arm. We had to cut it off. All right, young students. When was the last time you've been to the beach? Anybody go to the beach? Right? Yeah? So when you lay down at the beach in the summer, it's nice and you stay a little bit too long and you get a little blister because of sunburn, right? Or you touch the hot thing and then it blistered a little bit. Do you go to the hospital for that blister? No. Nurses, you pop it and then put a Band-Aid on and call it a day. That's it. Because in contact, sunburn, the skin is the first thing to get damaged. Everything else inside is fine. However, with extravasation, with medication burn, it's the last tissue to get damaged. The last one. What's under our skin? What's under our skin? Let me know. Let me get you started. There's veins. What else? Tissue. What kind of tissue? Fascial tissue. What else? Nothing else is under our skin? Muscle, arteries, nerve endings, lymph nodes, lymph vessels. There's lots of things that have been damaged. So much damage that they said, you know what? We're going to just cut off the arm. So his arm is gone now. And that's because of us. We neglected the patient. We need to fix that. Also happens to our babies. This is neglect. This is because we were not monitoring properly and we didn't believe the patient when they said something is wrong. We have to be very careful about that. All right.
Most CT protocols to deliver the desired image quality. Extravasation is an undesirable complication. Catheter placement, catheter movement inside the vessel, unhealthy vein condition, or even the impact of contrast on the vessel at high flow rates.
Look at that. That was water. That wasn't wood. That was water coming out with enough pressure. Water can move a human body. If water with enough pressure can move a human body, what's going to happen to our catheter with enough pressure? It's going to move the catheter. That's what's happening. It's not rupturing the veins. It's pulling it out. It's pushing it out from the high pressure. So we have to be careful with the catheter pistoning. It coming out is a problem and we must address it. Don't ignore it. This is for our leadership. Ultrasound insertions. Nurses are now, still in the US, it's not widely accepted. However, it is becoming very quickly growing that nurses are putting in ultrasound IVs. I've been doing it since 2016. There are nurses who've been doing it since the 1980s. How long does your peripheral IVs last? Your IV, how many days does it last before it goes bad? Yes, average of 3. Anybody have longer? Yeah, maybe 4 days, 5 days. With ultrasound, that can last 6 days. That can last 8 days. Is ultrasound going to guarantee that it will last for many days? Why not?
So it depends on medication.
Yes. I didn't think about that, but yes, that's a good one. What else?
Flushing style.
It could. It's because of me. I can still miss. I control the needle. The ultrasound doesn't control the needle, so I can still mess it up. The reason why I say that is ultrasound can increase the potential of success, but it's not going to guarantee it. That's our practice. How much are you practicing it, and are you getting better at your skills? But it's possible. My patient, a 35-year-old, hers lasted about 3 days, maybe 5 days if we got lucky. I put one in here, 22 gauge, and I told her very gentle, slow one push, no pulsatile, just do it very gently. Guess how many days we were able to keep it in? Give me a number. 5 days, go up. Anybody else? 7, go up. 10, go up. 15, go up. 20, go up. Almost, 28 days. We kept it in for 28 days. We didn't have to keep poking her multiple times. No infections, just thrombosis, and then we pulled it out when it was done. That's it. So it's possible. My friend had a PIV here, or put in a PIV here, 3 months, peripheral IV. If it's well maintained, if it's well inserted, it can last a very long time. How happy do you think that patient was that we didn't have to keep poking every couple days? Not just happy, but it's also reducing risk for infection. Every time we poke the skin, there's a risk for infection. How much of the bacteria is killed when you clean? Do you guys clean with iodine, alcohol, or chlorhexidine? Alcohol? So when you clean with alcohol, how much of the bacteria gets killed? Not 100%. So we're always introducing every venipuncture, every blood draw, even if you clean perfectly. How many seconds are we supposed to clean the skin? 30 seconds. Even if we did it for a minute, there's still bacteria left in there. All right, so pulsatile versus laminar. I say pulsatile flushing for CVCs. This is a theoretical recommendation. We still need practical data to prove it, but the theory is still there. And laminar flushing for PIVs because they're so small. Now, we do pulsatile to increase turbulence, and turbulence increases shear force. That's good for the inside of the catheter. But then what's happening right outside the catheter? We're still causing turbulence, we're still causing shear force in the veins. All right, when you flush too hard with the central venous catheter, this is what happens.
Here we go.
4 French, single lumen pick. If it's supposed to be here, why does it end up here? Why did it go up in the neck? Because the nurses were pushing too hard. Or the patient's coughing a lot.
Almost there, but it hasn't dropped yet.
Or the patient is ventilated and there's a lot of thoracic pressure fluctuating. So those are different ways, but a lot of times it's us. So here's a study to prove the math behind it. Bernoulli effect, Poiseuille's law, Venturi effect. How many of you took physics? Great, so you'll learn something today. All right, so from a 3 milliliter to 10 milliliter, which one's gonna help you to push with more pressure, the smaller or the bigger? So, ooh, yes, I got this one wrong. Yes, it is a smaller one. What about for less pressure? Less pressure is easier with smaller or bigger? Bigger? You would think, right? It's actually also smaller. So we have to rethink what we understand about this. Do you guys have a rule in your hospitals? You're not allowed to flush with the smaller? Good, all right. This is a graph that explains the potential ability of the smaller versus larger. And you're going to experience, I'm not just telling you this, you're going to play with it at the workstations. You're going to feel it and you're going to see it. Okay, Poiseuille's law. This is the fluid equation, the fluid dynamics equation that explains how pressure changes due to the radius and the skinniness of the diameter. Don't worry, this is not a physics class. I'm just going to skim over the math part. I just want you to know there's mathematical proof, okay? And don't feel bad. I looked at this equation for 3 months, just staring at it, trying to figure out what it meant, because someone told me you need to know this equation. I was like, okay, what the heck am I looking at? So we're going to skip a lot of it. When we look at, look, compared to this monster, when we look at this tiny syringe, does this look scary to you? It's so cute. It's like a little baby. It's a small liquid. It's a little bit of medication, and you want to be so careful and gentle with it, right? This is what we think because of the size. It's not. It's a freaking monster. It can push harder than you think, and I'm going to show you, and you're going to find out yourself. It can do so much, not just high pressure, but also low pressure. Okay, because of this, it's power 4, we're going to move on. I promise you I'm not going to do the math too much. Q, what does Q mean? Q means us. We control Q, and Q is the most important part. Okay, let me show you why.
This is a 3 cc syringe. 168. Did you catch that? Great. So this is how much pressure I believe we should apply. Okay. Less than 1 psi.
What is this a picture of? Yes, good. It's a tire. What does it say that the max pressure should be for tire? So something feels suspicious here. What did I do?
100.
This is a tire exploding at 170. What did I do?
This is a 3 cc syringe.
I love it. Your reaction is perfect.
168.
What?
Did you?
Okay, look at that. This is 170. And this is what I
This is
did.
a 3 cc syringe.
Where'd it go? With this.
160.
Okay, this is a car exploding beautifully. Now, am I going to blow up a child or patient's arm if I flush really hard with this? Is that arm gonna poof? No, of course not, because the volume is different. The volume of a car tire is a lot. There's a lot of air in there. There's a lot of volume. So the punch is gonna be harder, but it's still more. I can still put a lot of pressure behind this flushing, even if it's a small volume. Remember, with the smaller scale, what's happening to the tiny cells? What's happening to the endothelium? What's happening to that protective glycocalyx protein? Something to consider. All right, so how many of you draw blood from a PIV, peripheral IV? No? Only new needle? Do you draw blood from an IV? Okay, do you draw blood from an IV first stick or after 1 day, 2 days? Ah, perfect. So pediatrics, they don't care because they do it right. The adult side, however, we don't do it so well, okay? The reason why some hospitals have rules you cannot draw blood from an IV is because we keep hemolyzing the samples. We keep ruining the samples, and we're wasting so much money. The hospitals are saying, no, stop, please. We're losing so much money. Just don't do it. Just poke the patient another time. I'm hoping to give you guys a solution of how to reduce that hemolysis, especially for pediatrics and even adults. Hemolysis versus cavitation. Cavitation is the wrong word. It's barotrauma. That's what we're concerned about. All right, so what you want to do is pull with low pressure. This is the key. This is why we're hemolyzing the samples. Okay, how many of you draw blood and send it to lab? Nobody? Students, did you ever draw blood? Okay, good. Nurses, do you guys draw blood? Or do you leave it for the phlebotomist? Anybody? Okay. This seems to be the same problem across the whole country. So we've done a few workshops, and I'm finding out that the problem is the same across all of Latvia. All Latvian nurses have this issue. In fact, Poland was here during the Congress, and so is Czech Republic. And I found out all of Europe, and even in the US, we all have the same issue for nurses. In fact, when I did some more research, I found out that the whole world, the nurses all across the world had an issue. In fact, when I did even more research, when I dug deeper, I found out that the whole solar system, all the nurses in Mars, in Saturn, and Pluto, they all had the same problem. In fact, I found out that the nurses all across the universe had the same issue. When we send it to lab, and we're like, yes, this is good. It came out easy. Now I send it. And then the lab calls and say, hey, it hemolyzed. It's your fault. We blame it on lab, right? We don't say, oh, I must have done something. No, no, no. Lab dropped it. Lab lost it. Lab screwed it up. It's not my fault. It looked good. It was good when I dropped it off. It's not. We're hemolyzing the samples before it even gets to lab. Let me show you why. Most of it's due to negative pressure. So this is the definition of barotrauma. So when we have a cell, a red blood cell, it's supposed to be nice and has a shape, right? So what happens when we pull too much?
In our blood, when we pull with too much negative pressure and why our blood is hemolyzing. So I'm going to
watch the bubbles.
That with negative pressure, pull.
How big did the bubbles get?
Look what happens to the bubbles. They expand and then collapse. Expand.
Do you see what's happening when I'm pulling on that syringe very hard?
So,
okay, so if the bubbles are expanding, what's happening to our red blood cells? Is this red blood cell going to work? No. So when we draw from the IV, give me that blood! We're ripping the red blood cells. So don't pull very hard, pull gently. Sometimes you'll have to pull, pause, pull, pause, pull, pause. What does the pause do? So, we're closing that vein because we're sucking so much so quickly that we need to give the blood time to fill back up. And then we aspirate. And then we aspirate. Okay, so give it time to refill at the tip of the catheter or the tip of the needle. All right, so that's one of them. Also, have you noticed that there's bubbles coming out? Did you notice when you pull sometimes a little hard, you see bubbles? Yeah, that's barotrauma. That's hemolysis. So it's not leaking. How many times have I said, man, why are there bubbles? Is it leaking when, is the medicine leaking? No. Is the flush leaking? No. Is the blood leaking? No. It must be leaking. It's not leaking, it's us cavitating or barotraumaing the blood. Also, this is homeostasis. Do you guys use the word homeostasis? Right? Homeostasis means natural for our body. This is natural pressure, 2.5. What is the pressure right now in the room? It's 1. Okay? So if we take it out of that 2.3 down to 1, the blood is always hemolyzing every second. Not quickly, but slowly. So we must send this sample as quickly as possible. The more time we wait, the more time it's going to hemolyze. Another thing, do you guys have blood tubes with colors? Like red, yellow, orange, not orange, green, blue, right? Okay. So when I was first learning, I'm sure I misheard my teacher. She said, when the blood has clots, it's no good. For the purple, that's bad, right? When there's clots, or the blue, or whatever else. And so we have the red, and I was like, oh no, it's clotting. Ah, it's good. So don't shake it, don't drop it. Also, when you only fill that tube, do you guys fill the tube all the way every time? No, Of course, the answer is no. Of course I didn't, right? I don't have time. This is good enough. Lab says 1 milliliter is fine. I'm going to send it off. When you leave that space, it's not space, it's a vacuum. So that vacuum is constantly pulling and you don't know. So I recommend pop the top, vent the negative pressure, and then put the top back on and then send it out. Okay? All right, so that's how you reduce the amount of negative pressure. This is the math to prove what I'm talking about with the data they collected. So it's not only the amount of pressure I'm pulling, it's also how long I'm holding that pressure. The time and the amount of negative pressure both add to hemolysis of the samples. All right.
Let's look at baseline to see what kind of negative pressure it applies. So we got to about -4. Now let's see what happens when we pull it with.
You're going to do this today. You're not just watching the video, you're going to actually do it at the workshops.
That. Now let's try with the 10 cc syringe. -13. And then we had different PSI.
Okay, who cares? I'm a student. I'm terrified of giving medications. What do I care about blood draws? Imagine if they call and said he's hemolyzed, do you have to do it again? Or can you just say, nah, we'll do it tomorrow? No, you have to do it again. And if it hemolyzes again, you have to do it again. And if it hemolyzes again, you have to do it again. It's wasting a lot of your time. So if we do it right the first time, it's going to save you a lot of time later down the road. All right, ANTT. Anybody change the dressing for central lines? Have you guys seen central lines yet? Okay, good. PICC lines, have you guys seen PICC lines? Good, good, good. Do you guys change it or do the nurses change it? Did they teach you how to change the dressing yet?
Yes.
Okay, good, good, good. At least they were exposed to it. All right, so this is what's happening.
Exit an alcohol solution each time. After preparing the skin with a skin protectant prep pad, fix the CVC with a sutureless securement device.
Did you see how much that catheter was going in and out? This is actually really good. This is better than me. When I was doing these insertions, or when I was doing the dressing changes, especially at the beginning, I was cleaning, I was being very careful. I was like, okay, it's clean, we're doing good, we're staying sterile. And then it came out 3 centimeters. I'm like, pushed it back in. So we have to be very careful about this. I didn't know it was such a problem until someone told me it was an issue. Of course, we're putting junk back into the body. Of course it's an issue. But I didn't know because no one told me, no one taught me. Everything I'm showing you right now, I didn't figure it out. I'm not that smart. I'm just loud. Okay? These are things that people taught me over the years. The experts, the researchers I get to talk to and have lunch with, they're telling me these things. And so we need to also try to start our practice good and not catch up. Here's another thing. This is more for the doctors. Sutures are not perfect. Do you guys use, does everybody use sutures? Stitches? Yeah, okay. So I talked to the physicians later this week. I was showing them different techniques for central line insertions because I placed these as well. And there's some, the doctors now know that there's an option, sutureless securement devices. Okay. So applying the dressing wet is also a big problem. Do you guys use chlorhexidine, iodine, or alcohol for central line changes? Chlorhexidine? Perfect. Chlorhexidine. If the chlorhexidine stays on the skin for more than 5 minutes, what happens? Wet. When it's on the skin wet for 5 minutes, what happens? It's a chemical burn. We like to say irritation because it's nice and it doesn't sound so bad. It's a chemical burn. Okay, if this thing is burning our patients, why are we using it? It's so dangerous. Why do we keep using it? Because it was designed to dry after 2 minutes, maybe up to 5 minutes. So we have to let it dry. It's very important because if it gets irritated and burned and they start to have a rash, now that site's going to get infected and we have to now take it out. So it becomes a big problem down the road. we have to pay attention. Also, it doesn't stay on the skin very well when we don't let it dry. Have you guys seen something like this before in the neck? Does this look familiar? Right, similar? Are all the equipment required to prevent an infection in here? Are we missing any device? Are we missing any equipment? Let's go over it. Do you see the sutures to hold it down? Is it there? Yes. What about the antimicrobial disc? Is that there? Yeah, that's killing the infection at the site. Is the tape, the dressing there? Yeah. What about this picture? Antimicrobial, dressing tape, suture box clamp, that's there. Is this going to prevent an infection? No. Everything's here. All the equipment is here. It's not going to stop an infection. What about this one? Is this going to stop infection? What about here? We've got suture, we got securement. We have the antimicrobial device killing bacteria, and we have the dressing. Everything is there required to keep that from getting an infection, but this is not going to stop an infection. Why? Because when they start drooling from the trach, it's going to go into that site. Because things are going to go into that site. Who's responsible for the dressing to stay on? Yes, it's the nurse. So ultimately, this is the nurse's fault. This is my fault. I'm a nurse. I should have kept this dressing intact. This is my fault. The patient got an infection because of me, ultimately. But whose fault was it first? It's the doctors or nurses, whoever's putting it in. The inserter, this is their fault first. And this is what I talked to the doctors about that attended the seminar. And they were not like, oh, no. When I left, that dressing was perfect. What did you do, nurse? When I was gone for 6 hours, what did you do to ruin this dressing? They didn't say that. Some doctors do say that, but not the doctors that I talked to this week. They said, oh, that is a problem. How do we make it like this? So I showed them. I taught them, go low in the neck, turn it down, and put it in a place where it's not going to disrupt that dressing. Is this easier than this, or is it harder? What do you think? Which one's going to be easier to keep that dressing still? This one. Why? Huh? It's down. Okay, down. What's pulling on this? Is the patient pulling on it? What is? Gravity. Yes, gravity. When does gravity take a break? At 12 a.m. or at 7 a.m. during shift change? It never takes a break. It's forever. This is impossible. The physicians who place this like this lead the nurses to failure. It is not only a doctor problem. It is not only a nurse problem. It is a team problem. And unfortunately for us who put it in, we started the problem and we are responsible for making it better or worse. If we give you a line that's impossible to take care of, we are responsible as well, okay? So those are the things I talked to. Hopefully they will listen and they will teach the other doctors that there's other ways to do this. That technique is not easy. It does take practice, but it's possible, okay? All right, so we can get here. The reason why I say this is as the physicians are first at fault, they were first responsible for these central line infections because they placed it. Nurses are responsible first when the patient's lines fail. Let me put it in here. And they do this. And the dressing comes off. Oh, come on. I put it in. I taped it. The nurse says, I taped it. It was beautiful. What did you do, patient? In 6 hours that I was gone. We say the same thing the doctors complain about when the patients ruin it. But who put it in? We did. When we put it in here, what do we tell the patient? Look, this is great. We got great blood return. It's going in well. You have a lot in there. The dressing's perfect. It looks so beautiful. Don't move your arm. Is that possible? How do they wash? How do they brush their hair? How do they eat without... They can't do it. We have caused the problem at first, just like the doctors caused the problem first. So I'm hoping, again, this is not just a blame lecture. This is to show you guys we need to take responsibility of the actions that we take at the beginning, not later. At the beginning, so that the patients will benefit long term. So everybody's responsible. I'm responsible. And trust me, it is so hard to be responsible. Let me show you what I mean. All right. What is this? They're talking, they're breathing, they're sitting next to each other. Is that glitter? Are they at a rave or a party or a music festival? Halloween. What is that? So if spit's going that far. By the way, when I leaned in like this, I was actually spitting on your face. When you sit at dinner with your family and your friends, and you're within 2 meters, we're eating each other's spit. She's so grossed out right now. Yeah, for all you germaphobes, give up. So how many of you are changing the dressings, your central line dressing, the PICC line dressing, with your mask on? Okay. Now, what about when you're putting in the IV? How many of you wearing a mask? I didn't. Yeah, I got it. How much bacteria, just by breathing, did I put onto the patient's site? And I'm inserting that and injecting that spit into the patient's veins, circulatory system. How about this? Here's the very uncomfortable part. So this is our catheter, and this is our syringe. How many of us are wearing a mask when we flush? How many of us are wearing a mask when we put the medication in? So all these things that we're doing, we're still infecting the patients, and we don't know this. I didn't know this until last year. How many insertions, how many tens of thousands of people did I put an IV into and change the dressing without knowing it was very important? This is one of the key components that we need to be aware of. We need to be wearing masks to be very careful so we don't inject and infect our patients. All right, so if that doesn't convince you to wear a mask, I don't know what will. Like, that's proof that I need to wear a mask. Anybody work in oncology or want to work in oncology? Okay, you already heard my talk. We're gonna move forward. This is pressure. It's caused by pressure. If you ever see this, this is the solution. It's very easy. Just put gauze underneath. Okay. All right. Catheter reflux. This is another issue. We're going to switch gears here. Blood flow. When blood flow is moved too slow or it stops, it causes clots. Let me show you where it's stopping on your catheter.
Wow, look at that reflux. Jeez. We're going to simulate flushing technique. I'm going to flush one more time just to be sure. Okay, now I want you to keep your eye here while you watch me disconnect. This is going to be the key.
Watch the catheter.
People do this. They take the hub off, they take the hub off, they take...
This is what happens when you don't clamp.
And then look what happens. Look at all that reflux back in. And then we clamp afterwards, thinking that it's not that big of a deal. Now here's the next one. We're going to connect it, and then we clamp.
When this happens, are you going to see it under the skin? No. You don't see what's going on, especially central lines, especially dialysis catheters, and especially PICC lines. You're not going to see it. It's too long. So this is happening all the time when we don't clamp properly. Did they tell you you're supposed to clamp before taking off the syringe or after you take off the syringe and then clamp? Okay, so they told you to clamp before. For which device? For central line catheters, but which needleless connector? Which piece? There's positive and there's neutral and negative. Neutral and negative you must clamp and then remove. Positive you must remove and then clamp. And you guys do have both types in Latvia. So you need to know, and you're going to do this at the workshop. Again, you're not just watching this, you're going to do it. All right.
So here's the problem with the majority of...
Here's another reason why your needleless connector is very tough.
I've had one of these stuck before, where you're like, I can't pull it out, I need pliers to disconnect this. That is because we have been doing this, holding it here at the hub and not at the needleless connector, holding it at the hub, disconnecting, reconnecting, disconnecting, while holding it here at the hub of the catheter and not the needleless connector.
So here's what happens.
Moving. And I'm going to show you how much.
This is what happens when you don't hold it in the right place, when you're connecting and disconnecting.
Our fault. We're doing it wrong.
So watch how much that thing will turn and turn and turn and tighten, tighten and tighten.
By the hub. Okay, that's one time. This is flush number 2.
You see how tight it's getting?
Mark. Okay,
That's not coming out.
This is going to be mark number 2. All right, cool. Flush number 3. Flush number 4. That thing is, look how much
So we are over tightening it and we don't know. So we need to hold it in the right place. This is how many different needleless connectors are there. Which one do you have at your hospital? That's a lot. Did you know that there's many? You don't have the last 3 in this country. Don't worry about that. But the rest of them, I believe they're in this country. You need to know which one you have because they do different things. All right? So anybody use portacaths for cancer, chemo, or long-term hematology? No? Okay, we'll move on. All right, so there's a flushing technique to this. Madra knows this. If you're using ports, ask her. If not, you're not even gonna remember this. Don't worry about it. There is a direction, but just know that there's a direction and you're gonna wanna look it up if it comes across. This is what happens when we don't flush properly. These are the ports. And so we have to take it out and then we have to put a new one in. It's a very invasive replacement. All right, so we're gonna start doing workshops. Thank you for your time. Linda's gonna go ahead and set you guys up for the hands-on part. This is the fun part when you guys leave my lecture. Thank you.